Got it. Welcome, folks. We'll be underway in literally seconds. It is 1 o'clock, so I will kick us off. Good afternoon, and welcome to the Hospital Systems Addiction Care Community of Practice meeting for November. This Community of Practice meets every month on the third Thursday of the month, and we are so pleased today to share our time with one of the greats, in my estimation, in the New Hampshire landscape of practitioners, Peter Fifield. I'll have more to say about him, but Peter is going to be talking today about motivational interviewing, tips and tools for talking change with patients. So if we can go to the next slide. This work is funded by the, we are here to promote the development of interdisciplinary hospital systems that identify, engage, treat, and coordinate services for people with substance use disorder to improve patient and hospital outcomes in New Hampshire. We are funded by our state division of State Department of Health and Human Services and the Bureau of Drug and Alcohol Services. This is coordinated by my employer, the Foundation for Healthy Communities, and Growth Partners, who are here, not so much in the background, but we're grateful for Stephen and Mana and the other members of the team who are making all of this go so very smoothly. So I'll turn it over to Lindy Keller in a moment, but Lindy is the person from the Bureau of Drug and Alcohol Services who supported this work, makes such a difference to us. And if we can go to the next slide, just kind of a quick overview of what we're doing today. We'll bring you into the meeting. We'll talk about some logistical issues, and I think most of us are familiar with Zoom and comfortable, and that's exactly the point where you'll experience a problem. Luckily for all of us, we have some very good people here, so if you are having any problems, and you can use the chat function, just chat in, and somebody from the Growth Partners team will step in and provide some online technical assistance to make sure that you stay connected throughout this meeting. Once we get through this, I'll introduce our presenter, and then we'll have the better part of an hour for him to make his presentation, which I have looked at, and it's just so excellent. Then we'll have some questions and discussion and close and talk about the next meeting and adjourn no later than 2:30 p.m. So with that, I would like to hand this over to Lindy Keller, who is with the Bureau of Drug and Alcohol Services, to talk about the work we're doing here and the connections to previous meetings and to build upon the framework that we're trying to establish.
Hello, welcome everybody, and I'm glad you're all here. This community of practice was built because of what Dan said with the foundation's work with a number of hospital systems across the state who were already doing some work around trying to improve their services with regard to dealing with people with substance use disorders. And the community of practice was designed so that people who are working in this sphere or are interested in working in this sphere could come together and share their knowledge and skills, learn some new things together, and do some problem solving together. So we started this out by looking at this as a major issue of really changing the system of how we work with people in medical practices who have substance use disorders. And in looking at that as a group, what was identified was that really what was needed to change was the culture, was to gather together a team of people, a diverse team of people who represented different parts of the hospital system to work together to figure out the best way to bring about change with regard to this treating this population. And then finally to identify champions within the system who would increase their level of expertise so that more people who were more at a novice level of trying to begin to do things differently would know that they had some in-house folks they could kind of go to and say, help me think this through. Having spent some time on those topics, what the community began to ask for was more concrete skills. So this year, what we've really focused on has been looking specifically at concerns around unhealthy alcohol use and alcohol use disorder, since so much of the context of things had been around opiates in the past, and recognizing that alcohol continues to be New Hampshire's largest substance use problem. Then we moved on to having one of our hospitals talk specifically about the work that they had done around training and practice change to try to, and this was their word, to try to eradicate stigma. That's an aspirational goal, but I was glad to hear that people are working toward that. And then the last session we spent on harm reduction, which again impacts any work with folks with substance use disorder. And that has led us to today. So today, what we're going to be talking about is, once recognizing that there may be problems with unhealthy use of substances, how do we talk about that with our patients? How do we begin to move them into a place where they're aware of the need to change, aware of the opportunities to change, and to begin thinking about change on their own? So increasing their motivation to move forward with maybe a different way of doing things with regard to their substance use. So that's kind of been the trajectory. I like to give people the context. And with that, I'm going to give it back to Dan so he can introduce our presenter for today.
Thank you, Lindy, for that perfect frame. I am so honored today to introduce Peter Fifield. Dr. Peter Fifield is the manager of the Substance Use Disorder and Integrated Behavioral Health Services at Wentworth Douglas Hospital in Dover. I first got to know Peter 2 years ago when we embarked upon what was labeled then an emergency department project to increase the ability to treat SUD. And Wentworth Douglas, under Kelly Mueller's and Peter's leadership and others, took that to heights that we could have never imagined when that project began, and it produced a cultural change model that was featured in an earlier COP presentation that is available on the Growth Partners website for you, and I highly recommend it. Over the past year, the foundation was successful in becoming an agent for a grant of approximately $1 million to disperse to the state's 9 doorways for the treatment of services related to alcohol use. And I got to know Peter in a different and perhaps more personal way. And as we worked through the issues that were attendant with that grant, I was deeply impressed by his incredible passion for treating persons who are experiencing substance use disorder, and also his skill. He not only holds a doctorate in this work, but he is part of the Motivational interviewing network of trainers. And in a casual conversation with him several months ago, it was just like it was an incredible learning experience. So Peter, I'm pleased to welcome you, and I'd just like to turn it over to you and to say welcome from the community, and thank you so much for what you do that saves lives, and for being with us and sharing with us today.
Well, thank you so much. Thank you very much, Dan. So just jumping off here, I was given controls, which might be dangerous, but hopefully you all are seeing. Dan, can you give me a thumbs up on seeing that screen? Excellent. Okay. So today we're going to talk a little bit about screening and the provider's response to substance use disorders in the medical setting. I'll get to the objectives here in a second. I have nothing to disclose. Dan just gave me a wonderful introduction. Thank you so much. I am employed by Wentworth Douglas Hospital and work through the doorway programs, as well as the integrated behavioral health programs, which are behavioral health individuals embedded within our primary care locations at Wentworth Douglas. So I'm fortunate to work with both of those programs. So the agenda, let's just talk about this real quick. So really, we're going to have we're taking a 20,000 foot view here of the concept of screening. How can we deploy it? why it's important, and as important as the screening process itself, how do you respond to that in terms of making it sort of effective or impactful to that individual that's actually being screened? Because really, in the end, that's what we're talking about. We're not talking about meeting a measure. We're talking about being useful, a utility for the individual, the patient, or the client. So, but I do want, what I'd like to do is front load this whole conversation and ask you to see this from the 20,000 foot view and how to deploy these techniques on a system-wide level in your location, right? We're not learning motivational interviewing today, right? That's a 2 to 3 day class. What we're doing today is just throwing out a hook and trying to, entice some folks to be like, that sounds like a good approach. We should do that. We should utilize that within our locations. And we're going to do the same thing with the screening concept as well. So we're just going to jump right in. SBIRT has been, I think it's, I don't think it's unfair, but SBIRT has been very clearly identified with screening for substance use disorder. But if you think about it more like largely, you're screening, you're providing a brief intervention, you're referring to treatment. That could be a PHQ depression screening in primary care, right? That could be any screening that we do in primary care. So although SBIRT has been attached to screening for substance use, I like to see it sort of larger, more generically as screening and providing any intervention at any level of care at any, whether it's a medical provider or if it's a clinician at a community mental health center or otherwise. There is a newer concept, newer than SBIRT, and it's the STIR model. And it really just simply means you're screening, you're initiating treatment, right? Treatment intervention, then you're referring. That can be deployed quite readily in integrated settings. We utilize this model a lot in our primary care settings with embedded clinical social workers, because they're not SUD specialists, but they sure can work on motivational enhancement and work on sort of even a harm reduction model with an individual and refer out if that need surpasses their expertise. So there are two different models. SBIRT is more so for the typical medical provider, right? A physician sits down, gives a screen to a patient, and they might have a brief motivational moment, but they're really going to refer out. If the screening is done by a community mental health center, by a mental health clinician or a social worker or a PhD provider or the such, you really might be able to sort of initiate that treatment right there and refer out as needed. So that's the difference between those two models. Why screening? Screening historically, it was substance use historically was very binary, right? It was like there's a problem or no problem. If it's a problem, it's so obvious that it's manifesting itself in behaviors that make me be able to see them. I literally can see what the problem is because however you're engaging with that substance, it has sort of diverted your behavior into something that I now look at you and go, wow, that's troublesome. And we know that there's a lot more to it than that, right? With the advent of SBIRT and sort of a lot of the research that has gone into sort of substance use just in general, we understand that there is a very significant continuum, a very obvious continuum, and that we have this sort of this top of the pyramid that is the disease state that we're really talking about with the lack of plasticity, neuroplasticity within the brain. But even pre-disease and low risk, there's a way to sort of intervene to sort of in a quote harm reduction manner to get individuals to sort of be healthier with their consumption. SBIRT and STIR, the goals of them really are to sort of intervene whenever possible at the appropriate level, right? So if an individual is going through the screening and the result is a low or no risk, the brief intervention is simply educating, providing sort of some information on healthy norms, right? With permission if they want to hear that stuff. If it results in a risky use, you might have a conversation with permission about, hey, could I educate you in a way that how this might be impacting your overall health. And if it sort of reaches this level of severity where it actually may hit the substance use disorder, moderate to severe, or what's in the science realm, the medical model they call addiction, it could be a direct referral to treatment. So there's different risks, and this is sort of everything, as Einstein would say, everything is relative and everything is on a continuum. And so we in the medical field like to put stuff in little boxes, but we sort of, if we we dig a little deeper, we understand that those little boxes sort of had a lot of gray on each ends. And this is where SBIRT fits so well, because we can intervene with the appropriate measure at the appropriate time. Just real quick, touching on what addiction is, just in general. It's a complex psychophysiological process that really manifests itself in the individual's inability to sort of have control over their pursuit of this temporary pleasure and relief, right? They just lose control of that. And I'm not going to get into the DSM because it has 11 different components and all that. This is just really seeing it in a way that the individual sort of is suffering negative consequences. They can't stop. The relief is getting, it's existing and pleasurable at first. And as we go along the continuum of addiction, the relief becomes less and less, and it becomes more of avoidance of displeasure than it does a pursuit of pleasure. But like other chronic illnesses, it does involve cycles of remission, right? And relapse. And if we can get sort of, you hear this over and over, if there was a chronic disease model that treated substance use disorder like we do diabetes, we'd be discharging individuals out of the hospital, right, directly into treatment with a coach, with, the equivalent of, glucose monitor and an exercise regimen and all these things that we do for individuals with diabetes. We'd be doing them the same thing for them if they were discharged with a substance use disorder. So seeing it as a chronic illness is very helpful in many ways, yet not losing sight that it's on this continuum, right? So this is a sort of, I don't know if you can see my pointer here, but when we're talking about sort of intervention on a clinical therapy level, it's really on the regular heavy and chaotic use, or this abuse and problematic abuse on the right side. The less sort of clinical, the more conversational stuff can happen with experimentation, occasional moderate use, even up to regular use. And there's a lot that can be done within the sort of model of harm reduction within that realm. You can gain a lot of ground with individuals seeing substance use through a harm reduction lens in those sort of lower ends of the spectrum, if you would. This is just throwing this out there. I thought this was really interesting. So 2018 and 2020 statistics, New Hampshire ranked 5th on the highest drug use score, which is really interesting. And they give you a score on terms of like, how problematic is it to the police, to the legal system, to the medical system, to the individuals responding. So we were ranked 5th, and out of all of our United States that we live in, New Hampshire was ranked 1st in alcohol consumption. Lindy, I heard you mention that earlier, right? Alcohol is a significant problem, yet we have it on the highways and the byways. And you go to Maine and you can get it at every gas station, So, and this 4.67 is actually 4.67 gallons of alcohol consumed on average per year in New Hampshire. So screening for this stuff is essential. These are the types of screens, right? The National Institute of Alcohol addiction. I forget what the AA stands for. Anyway, they have a single item question. It's really, do you drink alcohol, and do you consume substances, illicit substances? That typically in most medical settings then triggers, the audit C, which is a 3-question, or the audit, which is a 10-question for alcohol, the DAS-10 for substances, the CAGE the CAGE aid for substances, or the CRAFT for individual adolescents. These are all, they're open source screeners. You can get them anywhere. A lot of EMRs already have them built in. So if this was a process you wanted to sort of engage within your whole system, a lot of times these already exist. So now that we talked about that, let's just talk about, so this is where that was the SBIRT side. Now we're going to talk about sort of the what next side. And SBIRT, screening, brief intervention, referral for treatment, and the initiation of treatment and referral. What I love about it is it opens up a dialogue, right, between the provider and the patient. And that can improve not only the relationship between those two, but it shows the individual that person, that human, really cares about my overall health. That's why they're asking me about these questions. And a lot of times, I still go to my doc and they're like, oh, you're not depressed, are you? Right? They tell me I'm not. And it's like, just ask me the questions. You don't have to be afraid, right? But we think that there's some kind of like stickiness in there. And if we can just get by that, we can sort of really get down to a really meaningful conversation. And that is it goes to speak with depression, with anxiety, with alcohol use, with all of it. So it's just normalizing it to asking questions about suicidal ideation, right? That's a really sticky one. That, you know, the more we norm that conversation, the more we can ask and discuss it. So this is something, this is, if we get nothing out of this conversation, I hope this is what we take. So the combination of trauma-informed care, which we haven't talked much about, but I know you all know about it, and motivational interviewing is simply being a kind human, right? And if we can be a kind human, we can sort of be more likely to engage with an individual in a meaningful way about behavior change that's important to them. That's why this is where this is really at. And if we take this universal precaution and engage with individuals all in the same way, in this way, then we don't have to worry about who has a trauma history, who has a SUD, right? We don't have to worry about that stuff because we're engaging with them all in the same way, expecting that they do. So now we're going to talk about the interaction, right? We talked about the screening briefly. Now we're going to talk about what we do, right? There's this result of the screen, and what do we do with that? Before we can do anything, we have to kind of create a place of safety, right? And a basic fundamental model of communication is that this person on the left, this X person, they have something to share. They step into the zone of safety, if you would, and then they step back out. And then you have the person on the right. They step in that zone and step out. That is a nurtured environment, right? If we don't intentionally nurture that environment, what happens is you get this perception of conversation. You get this perception of communication. And we've all been there, right? We've all been there. If anyone has a kid, a teenager, we've been there, right? We get this like, oh yeah, I heard everything you said, sure, right? And they heard nothing. So because we all just want to be in this safe place, and we all want to be respected and honored in our integrity. So we say, yeah, but we don't really listen. Okay. So creating this safety zone is a sort of really important bit, because I love this quote. One of the single most significant problems in communication is the assumption that it happened, right? We assume it happens all the time. And motivational interviewing is a wonderful tool for clarifying the communication model, if you would, right? What actually happened there? What took place? What are we both walking away with? And how do we know what our plan is at the end? And like I said, no one's going to walk away from this 40-minute discussion an expert at MI, but this is the sort of fundamental purpose of motivational interviewing. We know conversations can be super frustrating on both ends, right? It's not just frustrating for the patient, it's frustrating for the provider, right? They're like, are they even listening to me? And the patient's like, are you listening to me? You know, is anyone, and no one's listening to each other because we're not creating, intentionally nurturing, for the most part, the space of safety. And a lot of times the space of safety goes away because of a time crunch. That's really what we're talking about, right? I mean, if we had all day long, we could be like, yeah, let's sit down and let's make a cozy little space and we'll hang out and we'll talk. And a lot of providers, I worked in an FQHC for 10 years. I get it. You know, I mean, they're the providers, they got 10, 15 minutes in between patients, super complex. They got all these questions, and you want me to sit and make a place of safety and listen and be like, you know, like it's hard. It's totally hard. The wonderful thing I like about motivational interviewing is it's totally possible. You just do it in chunks over time. And a lot of the times when I train docs and medical providers specifically, we talk about doing it over time, not just this one intervention of motivational interviewing, because that's really hard, right? It's to, so you do it in inches and increments. And in the end, we'd all rather be less frustrated, right? And be more effective, because that's why we go to work. We go to work to make a change. We don't go to work to be frustrated. So, all right, so the nitty and gritty of motivational interviewing is really the concept of change. And there's all kinds of studies about motivational interviewing, and some of them, most of them, are all distilled down into this concept of internal motivation, creating some sort of positive change in a direction, in a health behavior direction, right? And so we're literally, you distill all those words out. We're just talking about changing behavior, okay? And there's also a lot, I mean, motivational interviewing book, I've got it right there. It's like 500 pages, right? It's huge. It's a big, huge book. But when you distill it all down, this was a study out of the, I think her name is Denise Lorig, or Kay, I forget actually. But she's living in healthy life and chronic conditions. She did a lot of work on predicting change. And one of the key predictors of any change is not how successful you've been so far, it's how confident you are in the next step. Said otherwise, if there's 10 steps and you've made 9 out of 10, that's less important than taking 1 out of 10 and being very confident about that second step, right? So this is really what we're talking about. We're talking about confidence and control over your entity, yourself, your autonomy, moving towards that next step of behavior change. And how you get through that as you're navigating this concept of ambivalence. Ambivalence just means seeing things 2 ways, right? So we want to take the wants and the needs, we filter through those, we enhance those as best as possible. After we've enhanced the wants and the needs as much as possible, we try to take away some of the obstacles and make a plan towards change. Super oversimplified, but that's, in a nutshell, that's what we're talking about. So when we talk about confidence, right, we're really talking about this concept called change talk. And all change talk is more talk about I want to, right? And sustained talk is all this talk about I don't want to. And the more we get people to display sustained talk, I don't want to, where to go? Right here. The more people we get to display change talk, the more change we get. The more people we get to display sustained talk, the less change we get. Plain and simple. And that's what, like you distill down all the meta-analysis. There's so many of them over the past years. You distill them all down and it's get change talk, right? So really then the question is, what do I need to do to sort of engage with this individual to enhance the change talk and get them to start talking more about what I want and less about what I don't want? And that really is the art and the nuance of motivational interviewing, right? I mean, because motivational interviewing isn't just something these tools we'll talk about in a minute, throwing them all together, checking off I got the spirit box, and then all of a sudden the individual at the other end, you have this change product. It's really about sort of how do I get the individual in a very artful way to talk more about their change. And you'll see this slide. This was from '93. This is when, before they changed it to sustained talk, they called it resistance. They kind of changed the word resistance to sustained talk, but they're pretty much synonymous. They're the same. So what is change talk, right? Change talk are these. There's a really not great acronym, but it's called darn cat. And D is desire, right? You listen for words about desire. You listen for words about ability. I could, I know I could. Reasons, this has to happen. I need to. And those are all those are important words to hear, but these commitment, activation, and taking steps, those are really the kind of I've already started to think about this. I want to. I've really kind of taken this to the next step. And according to the stages of change, I might have even been in action mode. I'm taking that next step. I'm not super confident yet, but I'm going there. And that's when you hear things like, I promise I will, I'm ready to, I've already have done X, Y, and Z. So essentially, you hear these words and you enhance them, right? I really have to do this. Tell me a little bit about why you have to, right? And then that's how you kind of continue this strategic conversation. So one of the things that we have to this is one of the harder things in the medical profession, at least, is tuning into the right signal, right? Because hearing change talk means we have to not hear or hear at the same time as the other problem talk, right? Because problems are what physicians and nurses and medical providers, that's what they do, right? They're like, this patient says, I've been thinking I need to lose weight. I went for a walk. Afterwards, my left knee was hurting badly. It was throbbing mostly all night. I took some ibuprofen, but it didn't help, right? So the medical lens is, I need to fix that problem. I need to help this individual. And we can't ask them to forget that. However, look at this. This is the key motivational interviewing statement, right? So when we look at this and I've been thinking I need to lose weight, we can't lose that. We got to fix the knee. right? And we got to be like, hey, okay, that's going to be better now. Hey, tell me a little bit more about this weight loss thing. So we can't, it's not like, so it's kind of, it gets to be a trick with medical providers because we're asking them to do two different things. We're asking them to look at the problem, solve the problem, yet be solution oriented and look at this change talk too. And it's hard. I mean, I'm not saying this is an easy endeavor, but this is really where we need to pay a lot more attention. And oftentimes you hear sustain talk and change talk at the same time. This is called ambivalence, right? I really don't want to stop smoking. I've tried to quit before. It's really hard, but I know I should. I want to exercise. So you're hearing both sides of that. I can't do it, but I want to do it. So this is sort of when, once again, with that, the sort of the strategies and the nuance and the art of motivational interviewing comes out is, hey, tell me a little bit more about why what benefits would you have from exercising? Instead of being like, wow, you really did try. I know it is hard, isn't it? Right? Because you do that and they're going, oh my God, it is so hard. So you get more of that sustained talk. So you see the nuance there. It's focusing on the change and not the sustained. So now we're going to go right into Prochaska and DiClemente's sort of concept of stages of change real quick. We're not going to spend a lot of time here. Motivational interviewing really, we're going to talk about the spirit of motivational interviewing. And when we talk about the spirit of motivational interviewing, it can be used anywhere, anytime with anybody, right? It is essentially just sort of engaging with a human at a on a human level. That's it. You're just like having a good conversation that could be somewhat productive, possibly. When we talk about the skills and tools of motivational interviewing, you deploy those when an individual is contemplative, maybe pre-contemplative, maybe, mostly when they're contemplative and preparing, because that's where ambivalence lives, right? That's when you want to move the individual from the stay in one place to the change place. But if they're pre-contemplative, they don't even want to yet. Right? So a pre-contemplative person responds to motivational interviewing like, yeah, whatever. I'm good. And you say, okay, you know what? But if you change your mind, we're here. Right? That's how we respond in a very generic way to someone who's pre-contemplative. And same with action. You don't want to get in the way, right? You don't want to be like, oh, no, wait, let's think about this some more. You want to be like, hey, you're doing great. Let me know how I can help. We're always here. So the tools and the tricks and the trades and the nuances of motivational interviewing are really in contemplation and preparation phase. So how do we get someone to talk about, let me reverse that. Essentially, when we do this, we get more change talk, we get more change. This is super distilled out in the simplest way. We get less change talk, we get less change. Right, so that's the nuance and the focus of motivational interviewing. So let's real quick talk about what motivational interviewing is. And this is a lot. It's two parts, but it's kind of important to take it all in. Motivational interviewing is a collaborative, goal-oriented style of communication with particular attention to the language of change, which we talked about, right? We're looking at that language of change. It is designed to strengthen personal motivation for and the commitment to a goal, a very specific goal, by eliciting and exploring the person's own reasons for change within an atmosphere of acceptance and compassion. Now, that acceptance and compassion, that atmosphere is what we're going to talk about here soon when we talk about the spirit of motivational interviewing. That was that safe zone that I was talking about in the beginning with the X and the O. You create that safe zone, that atmosphere of acceptance and compassion through the use of the motivational interviewing spirit. So very simply put, standard of care, right, historically used to kind of, in a very oversimplified way, you, the patient, are an empty vessel. I am the provider with all of this knowledge, and you're the empty glass, and I'm going to fill it up, right? And you're going to walk away enlightened, and everything's going to be wonderful. Really, and that's great and super simplistic, but we just know it doesn't work. Right? It works for like 5% of the population. There really is a very clear, distinct subset of population that says, tell me what to do and I'll do it. Right? They exist. It does. And we have to accept that. And those people, you're like, yeah, absolutely. And they follow through with the plan 100% of the time. It's a very small subset of the population. So what motivational interviewing does is it's more like siphoning, right? You're evoking out of the individual, you're siphoning out of them what they know first. So then, I mean, it's really, it's a win-win. They get to tell me or us what they already know, and I don't have to waste time repeating things that they already know, right? I find that out first. I find out what is in there, the expertise that's already existing, and then I supplement with my expertise, right, of whatever skill I might have that complements their expertise in being self, right? Because there's two experts in the room, the clinician and the provider. I mean, the clinician and the patient. So how we do this, we first start by hopefully assuring that these 4 components of motivational interviewing are in place, right? And they are, the first one is compassion, right? And compassion really means in the motivational interviewing realm that you're actively promoting the other's welfare and giving them giving priority to their needs, not our needs, not our check boxes, not our time limits, all that stuff, which I know we have to live within. I know that, but doing the best that we can to actively promote their well-being, even within the chaos and the rigidity of what we have to operate within as a medical provider. Collaboration is really understanding that this motivational interviewing or this interaction I'm not doing to someone, I'm not like am-ing them, right? It's a process that we do together. And it's so overused and somewhat trite, but there is some legitimacy to the old saying of don't walk in front of me, I'm not going to follow, don't walk behind me, will lead, walk beside me, right? That is really what the essence of motivational interviewing is just being side by side and being like, hey, let's work on this together. There is the evocation, and the evocation is fundamentally actively pursuing what is already existing in the individual and trying to get that information out first. Tell me what you know about weight loss. Tell me what you've tried already about quitting smoking. Tell me what your thoughts are on, right? That's getting out of them first. You know what you should try? You should try running. That's the opposite of what we're talking about here, right? Because they're like, I already tried running. So if we say to them, if we evoke from them what they've done in the past, tell me where you've been successful in the past. Oh, I really tried biking and I didn't like it, but I tried running and it was great. Then I don't have to give a suggestion because they brought it out right there. So that's the art of evocation, is sort of understanding that what lives within them is the majority of the change already lives within them. And then the last bit is acceptance. And I waited for this because acceptance has 4 components. And one of the overall gist of acceptance is your approval or disapproval of their behavior is irrelevant, right? I don't technically need to approve of an individual injecting illicit heroin to work with them. I don't have to approve of it. It's irrelevant if I approve or not, right? It's approval or disapproval of a behavior. It doesn't matter. However, within this acceptance, right, if I can give them absolute worth and just be like, you have worth just simply because you're a human, regardless of all your behaviors, your traits, any of that stuff, you have worth because you're a human. You have autonomy to do whatever you want. You can stay or leave. You can work with me. You don't have to. Let's do this together. You have that free choice. If I provide accurate empathy, which is not sympathy, right? Sympathy's getting in the hole with them. That's gross and like cold for both of you. Empathy is being like, wow, that's cold and yucky down there. How do I help in an accurate way? And I can provide affirmation like a coach. Hey, you can do this. If I do all 4 of those things, my acceptance or disapproval or approval is irrelevant, right? That's where acceptance, that's why sort of the authors of motivational interviewing had to divide acceptance into 4 different things, because it was a really complex concept to wrap their head around. So if we do all of this, right, we are then able to sort of create this environment that we can have a true communication change or exchange, if you would. And I love this, Teddy Roosevelt, no one cares how much you know until they know how much you care, right? They want to know that first. Do you care about me? And if I know you care about me, I'll listen. If I don't, you might get half an ear. Maybe I'll listen a little bit, right? So we have to, that's that nurturing component, that space, that zone of safety that we have to hold on to. And if we do that, once again, coming back to here, this is just kind of, this is like subliminal messaging, but not so subliminal. I keep coming back to this, right? The more consistent behaviors we give or exhibit, the more change talk we get, the more change we get, right? It's very clear over and over and over, more directive, non-MI behavior gets less change, right? More collaborative, open, conversational, autonomous interactions in a motivational interviewing style get more change. And all of the evidence that I've seen shows that. Dan, how are we doing with time?
We are doing excellently. We are at 1:40, so we
Okay.
are doing quite well.
Okay, wonderful. So going on this theme of sort of motivational interviewing as the spirit of it, right? It is very much a dance, not a wrestling match, right? A lot of times interactions with humans, I don't know, and I'd love to hear an example where you've never had a wrestling match type conversation with anyone in your life. I know I have, and I don't like them. They feel uncomfortable. They don't feel productive. And you're like, gosh, that was not, I don't like it. I don't. So I couldn't imagine doing that on a daily basis. And this is where historically, I think it was great in the medical professions when we're just like, do this, and they leave. And then we're just like, okay, done. Which it wasn't confrontational, but we didn't get much change either. We didn't get a lot of health promotion. So we're really trying to, how do we do this whole process without confrontation and with a positive outcome, right? So that's where motivational interviewing has proven to be most effective, is creating the dance and the tango. I think this is the tango, and that sometimes seems more like wrestling than dancing. But anyway, it's a dance. So hopefully, right, we move this individual that is very contemplative into this action mode, right? They're ready to jump into the pool. So now let's talk a little bit about this. This is where the concept of motivational interviewing starts to take a lot more practice, right? Because these are the tools that we use. And these are the tools that sort of can be conversational. And actually, to date, I use these tools with my teens, especially, right? Because they don't want to be told what to do, but they want to be listened to, right? And but you still have to draw boundaries with them, right? You can't just let them run around willy-nilly, but you want to make them feel heard. It's I don't know. I haven't perfected it, but it's the closest thing that I've come to with engaging with a sort of a client that I might not see eye to eye with. I even say that wrong because it's not my agenda, it's their agenda. But you see where I'm going with that, right? Sort of a client that I'm like, how are we going to get this individual to sort of move from A to B? So the tools basically are, right? They're open-ended questions, affirming statements or affirmations, reflections or reflecting statements, and summarizing statements or summaries. So let's talk a little bit more about these in detail. So open-ended questions as a tool, right, are a way to ask a question that encourages people to talk about themselves, right? They elicit a narrative, if you would. Tell me a little bit about the last time you were really successful with quitting smoking. That's right. Like, oh my God, that's just inviting them to talk and talk and talk and talk. Now, if I said to them, have you tried to quit before? Did you use Chantix? Did you quit for more than 2 weeks? Was it hard? Right? I mean, those are all, I can get there eventually, right? But that's a lot of questions, and I'm doing most of the talking. If I say, tell me a little bit about the last time you were most successful, I just sit there, and a lot of those closed-ended questions that I was going to ask anyways, was it hard? Did you use Chantix? How long did it take? How long did you quit? All of those are answered after I just listen. I just ask one question and I listen instead of asking a bunch of questions to get their individual responses. So open-ended questions are really sort of a very strategic way to sort of get a lot of information at once. And there's a craft. The craft open-ended questions is learning which ones work the best, right? And that's beyond the scope of this. But there are some questions where you're like, oh God, I shouldn't have asked that. We've only got 2 minutes left. So I should, so there's a strategy to even the use of an open-ended question. Affirmations are the clinician's way to be a coach and a cheerleader for the individual's effort, regardless of how small, right? So a lot of times affirmations come easy. You've got a patient or a client that you love, and you're like, you're rocking it. This is so cool. When affirmations get really hard, it's the client that, and I say this, and it's the client that you could probably never see again and you'd be okay, right? Every clinician has that client. They're like, oh my God, X person is back. They're so hard. They're so difficult. They're so whatever. Affirmations for that individual are really, really hard to come up with sometimes, right? Yet that is the other part. My coworker of mine says that's why they call it work, because it's hard, right? That's the part of this work that is really hard, is doing your best to sort of mine for an affirmation. You're so determined. You were determined to be here. You really advocate for yourself really well, right? Those are kind of ways to spin what you might call manipulative or what you might call something else. You can spin that into a positive information. You really care about the outcome for you, right? You just kind of have to see it a different way. And what I've learned with affirmations, it was a physical, my own individual learning, a personal learning, and it was also sort of, it's been supported through research. They make the clinician feel better too, right? If I can think about the person as determined to not miss my appointment versus late again, right? I feel different about it, right? So it's kind of a burnout prevention at the same time. Affirmations help us feel better about our clients, which then allow us to feel better really about our own existence and ourself, because our lens is just slightly changed. The other thing about affirmations though, right? These are just some examples, right? I really like the way you showed a lot of courage, self-control. You have a real talent for, they're just ways to encourage. If an affirmation though is not genuine, you know what it's called? Sarcasm, right? So if an affirmation has to be genuine, because if not, it's really could be perceived as sarcasm. Nice work, right? Just changing the way you say something like that, nice work, can change the meaning. So if you truly don't mean it, step out of the room, work on it for a minute, and then come back in before you sort of just throw it out there, because affirmations, as I said, have to be genuine. And the affirmations are really sort of, we go back to kind of the flow of a conversation. We start to engage with the individual with an open-ended question. Tell me a little bit about, right? And then we keep them talking. Wow, that was really good. And then they're going on, and they continue the story, the narrative. Whoa, you really worked hard there. Yeah, I did. And then they keep on going. So affirmations are one way to keep them talking about until you get all that information that you need. And then it's also a way to sort of at the end, you can wrap it up. And sometimes we'll talk about this later. You can put affirmations in a summary, but we'll talk about that in a minute. So this next tool, right? This is the third tool, and these are called reflections. And reflections are really designed to help engage the relationship and build trust, right? And foster this sort of internal motivation of change, this want to on their part. And reflections are kind of like, if you think of visually, if you thought of an open-ended question as a tree in full bloom, that is an open-ended question relative to your brain. You could take any branch, you could go anywhere, you could go, literally go any path on that tree, up any limb. A reflection is trying to narrow the conversation down to one branch, right? Because you found a theme strategically, therapeutically, you found a theme that you want to stay on, a branch, if you would, and you don't want to ask an open-ended question to divert the person's sort of open mind to start thinking and going off on a tangent. You want to strategically close in the direction of the conversation and move it towards this change talk. That's where reflections really, really do their job, right? Because you're trying to sort of get them to think more about that one branch and that one tree that is now the therapeutic branch that you're pursuing together. Does that visual make sense? It just kind of came to me, and it sort of, reflections a lot of times can close the loop on communication. We mentioned earlier, one of the biggest errors in communication is the assumption that it happened, right? You reflect back, you say, oh, that was really hard for you. And they'll tell you if you're right or wrong. No, it was super easy. Oh, okay. Well, no way. Or I'll never forget, one of the physicians called me into, he said, hey, Pete, this patient down in room 3 wants to talk to you about quitting smoking. So I go in, So Dr. X told me you wanted to quit smoking. No, I just wanted him to stop asking me about quitting smoking. I was like, oh, okay. So my reflection was, right, you want to talk about quitting smoking. He clarified, nope, I don't. I want him to stop asking me. So then we start talking a little bit more and more. And it turns out that, he was having this conversation. He was having this difficulty with his wife. Like, God, you really love her, huh? Like, because it sounded like he's doing all this for her. I don't love her. I kind of just want her to stop talking too. So I think there was some sarcasm in there, obviously, but he was clarifying me. And I just had to be like, oops, my bad, and keep going with it, right? There is a Q-tip, a quit taking it personal realm or a component to this. Like you can't, if you miss with a reflection, they'll let you know and you go, okay. And then they clarify and then you roll on, you keep going with the clarification. So it can be really, really, really helpful in clarifying and closing the loop on the communication. There is a level of sophistication when it comes to using a reflection, and simple reflections, they call them, or repeating reflections can be used, but don't overuse them because they simply are parroting back what they said. I'm really tired. You're really tired, right? You don't want to keep doing that because that would be, as you could imagine, it would be very annoying. A lot of times basic repeating or even the subtle rephrase are for you to like come up with a more sophisticated one, because keep in mind the whole time you're having this conversation, you're trying to process what to say next and listen to it all, right? So the computer, the RAM is like on overdrive, and it's like you're trying to really make sense of it and strategically move this conversation forward. So sometimes you offer a simple repeat or a rephrase just to pause for a minute and get your mind to be able to sort of create something a little bit more sophisticated. Paraphrasing, though, on the other hand, is a sort of a major restatement, right, of the situation, or you're even adding words that they didn't give you, right? So they're going on and on about, you know what, this, and that, this, and that. And you're like, that's when you would put in there, oh, and you were really scared because of the heart attack you had a year ago, right? And they might not have said that at all, but you've got that information because you were looking at the medical chart, for instance, right? And you can just put that in there if you think it's relevant. So that's really paraphrasing in a larger, more creative way. And then creating a reflection of feeling is adding like that emotional piece. You're afraid, you're sad, you're mad. A lot of times the reflections of feelings, if you get it right, you most likely will get some emotion right then, right? You probably will, because they're like, you got me. And that's the other thing that reflections do so well, is when you're accurate with them, they know you got me. And they so appreciate you even trying to get them, right? But when you do, when you that kind of like that light finally goes off, they're like, oh, they really are understanding me right now. You'll most likely get a pretty decent reflection of emotion then. So reflections are the most powerful, in my mind, the most powerful tool, if you would, within motivational interviewing. Summaries, on the other hand, so summaries are useful too, right? We don't overuse summaries, because summaries are kind of like trying to tie up the conversation. They tie things together. They want to make sure you're clear on the details, and you say them like, this is a loose suggestion. You could use them in the middle and at the end of a conversation, right? Because you're really just trying to be like, okay, so wait a minute, Mr. Smith, let me make sure you've got X, you said X, Y, and Z, and that. And then you said your wife, and then, but you did this. Did I get everything right there? Is there anything that I missed? Right. And they're like, no, or yeah, you forgot about that part. And you're like, oh yeah, I totally forgot about that part. Okay, we got that. And then you so as I understand it, this is where we are. Where do we go from here? Right. So you're summarizing, you're putting this whole thing in motivational interviewing. They call it a bouquet, right? You got this, you took all of these individual flowers and twigs and sticks and all this stuff, and now you just put it all together and you're offering it back. And they're like, yep, that's it. And you're like, okay, that's the best clarification loop closer you could make, right? You now know that we're both talking about this bouquet that we both want, right? We don't have to throw anything out of it. We both want it. And now we can move on to the next step. So summaries are very, very, very useful in that way, that we are now identifying that we're on the same page. You can use collateral information, right? Stuff from the chart. A lot of times summaries include an arrest report, or like with clinicians, right? Or some sort of lab report or sort of external information. That's fine. Definitely try to be as clear as you can and concise with summaries, because what you're trying to do is distill out the chatter for them, right? So you want to take out the noise and give it to them in a nice clean picture. So adding noise and chatter to that is not what you want to do. So try to be as clear as you can within the summaries. And then at the end, invite, just say, hey, did I miss anything? Right? Is there anything that I said that you want to correct? And that could be the end, or that could be the middle, right? That could be just the beginning of the first phase of the conversation, right? But you're wrapping it up. It's kind of like a chapter, if you would, that you're just wrapping up and making sure where everyone's on the same page. So those are the 4 basic tools, right? They call them ORs: open-ended questions, affirmations, reflections, and summaries. And those tools used strategically with this concept of the spirit of motivational interviewing is how we technically, through practice and time, we get better at moving individuals from conversational ambivalence to conversational change to actual change, right? So, okay, now, because motivational interviewing does take a long time to practice and a lot of time to sort of get better at, a lot of clinicians like to practice just this model. It's kind of like training wheels, if you would, right? It's motivational interviewing training wheels. And it gets you kind of in the spirit of using this conversational style and interacting with someone. So really what we're talking about is called the elicit, provide with permission, elicit model, okay? So essentially, it's a patient-centered structure, right, for discussing recommended care. This is what we give to primary care providers to be like, if you don't ever learn motivational interviewing, just engage with an individual in this format, right? And if they do, most likely they're engaging in a motivational interviewing way, right? So it improves efficiency. It's way better than advice giving, and we've already discussed that sort of advice giving is less productive clinically for clinical outcomes than is the MI spirit and the MI intervention. It's easy to teach. It emphasizes autonomy, collaboration, and evocation. So essentially it goes like this, right? You begin the conversation by eliciting the patient's thoughts about a topic or a question. So you just be like, hey, Mr. Jones, I'd like to shift the conversation to talk a little bit about weight loss. Tell me a little bit about your thoughts about weight loss. So I'm eliciting, right, their thoughts. And this is the really interesting thing about motivational interviewing. If you remember the definition, it said goal-oriented. I can't have a motivational interviewing about a generic, hey, let's talk about being happier in life, right? You just can't do that. That's too generic. Weight loss, though, is a very specific thing, right? So you as the practitioner have to sort of narrow the scope of what we're talking about and having this MI intervention about down to a very practical behavior. In this case, it's, hey, tell me about your thoughts about weight loss. It could be, tell me about your thoughts about quitting smoking. Tell me about your thoughts about doing homework more. Tell me about your thoughts about getting on the bus on time. For all those school children we have out there, right? You can do this for anyone. Before we jump into deciding whether or not you should lose weight, please take a minute to tell me what you know or have heard about the weight loss and how it relates to your blood pressure, right? So it's just kind of, that's another open-ended question, eliciting to them, asking them, inviting them to talk about it. You just kind of gussied it up with another clearer, you kind of narrowed it down, weight loss and blood pressure, right? So it's all an open-ended question to elicit them to talk to you. Then, after assessing the patient's thoughts, feelings, knowledge, and all of that, you begin to shift back from their expertise to your expertise, right? But before you do that, ask permission, right? And that's where this provide with permission part comes in. And it can, I mean, asking permission, a professional asking permission, like sometimes just blows people's minds. They're like, whoa, yeah, of course you can. Right? I mean, but they're not used to hearing that. They're like, well, I mean, I love hearing responses, the feedback from medical providers that actually say they do this the first time, the response that they got, right? Because typically, like, they're just not, patients aren't used to hearing it, but they totally appreciate it. They're like, you value me enough to ask me if you can give me wow, yeah, sure, right? So it's communicating respect. You're encouraging the patient to use their voice and telling them, I care about your perspective. And you're focusing back again on the patient being the second expert in the room. You're not the only expert, right? You giving them that respect of asking them is like, whoa, I'm good at this. I'm an expert too, you know? So it kind of levels the playing field a little bit, which we don't have enough of. And there's a significant hierarchy, whether we accept it or not, in any medical setting, between the provider and the patient. So it levels that a little bit. So you could simply say, you know what, I've got an idea. It's very relevant to what you just shared. Do you mind if I share it with you? Right? Everything you just said really got me thinking about something. I've got a great idea. You want to hear it? What do you do if they say no? They probably won't. Right. Susan, I could read your lips. Don't give it to them. Right? Don't. And it would probably be, you're like, well, why would I ask them? Well, because you care about them and you respect them. Ask them. And if they say, no, I'm really good, actually, I've got enough pamphlets on smoking, right? And how it impacts my life. Okay. Well, if you ever want another one, come on back. I've interacted with nurses a lot in my life, and God bless. My mom's a nurse, my grandmother, nurse, two of my sisters, nurses, God bless. And they have this thing in motivational interviewing world. There's not nurses, but some of them do have this thing called the writing reflex, right? I have to fix this. They have to leave here better. And if they don't, darn it, I didn't do my job. Well, there's an old saying in motivational interviewing, you're only responsible for the intervention, not the outcome, right? And nurses and medical providers really struggle with that. They're like, no, you get that all wrong. I am responsible for the outcome. But in essence, they're not, right? Once that person leaves their office, they're gone, right? So the best thing you can do is invest 100% in that intervention right then, and then hope they do their best. So if they say no, okay, perfect. Come on back when you're ready. If you're ever ready, or if you ever want that, you come on back. We'll be here. And then you engage with them in a non sort of judgmental way. Next time they come in, hey, you're back. Not, oh yeah, I knew you'd come back, right? It's okay, come on in, right where we left off. So this little provide with permission part, I think, is sort of really where the essence and the spirit of motivational interviewing can either go, it can bloom or it can tank pretty easily, right? So paying attention to that. So you ask them, hey, can I provide this? If they say no, we don't, it will damage the relationship. And it actually, this is the change part, it guarantee they won't change, right? I'll show you, is really what happens in the end. They're like, okay, you know, so they get, I wouldn't even say obdurate, they just get more secure and entrenched in their perspective and less likely to investigate or sort of entertain something outside of theirs. So just let it be. Okay, cool, come on back. But if they do, you know, you give them your advice, right? You're the second expert in the room, as we talked about. And then you're like, you know what? Tell me a little bit about what you think of what I said. I just had 3 different options. Which one do you think might work best for you? The third one, I know it sounded really expensive, but the second one, really, I know a bunch of providers in your area with that insurance. What do you think about that? Right? So you're just you gave them an expertise, and then you're asking them what they think about what you shared. So you just do this over and over, right? Until you come to a natural point and you reflect and you listen and you give affirmation. Wow, you really worked hard on that. Or, wow, no kidding. Your wife said something about that last time, but you weren't sure how she was going to respond to that, but you did it anyway, right? You're hearing this conversation the whole time, reflecting, and finally you'll get a natural pause. Or you'll have to come, you know, your 15-minute visit is over and you're like, hey, Mr. Smith, we got to wrap this up. I know we talked, let's talk more later. Okay. We'll do this X, Y, and Z now. I know we haven't finished that, but we can get to that next time. Let's wrap this up and then come back and talk some more. So there's ways to do this, very MI style oriented in segments. It can be very effective. And once again, I love this quote, you're only responsible for the interaction, not the outcome. And that is Stephen Andrews, I believe. He takes credit for that wisdom right there. So that's all I have. And I'd like to, I guess, open it up more so for like conversation than questions. I mean, I'll answer any questions anyone has, but I'd love this to be as conversational as well. Did I stop sharing?
You did.
Excellent. Okay.
And I'm just, I'm taking a breath here. I'm inhaling, and that was just terrific, Peter. Thank you. Please feel free to unmute and ask questions. We're a rather small group of 15 at this point, so just jump in. Apparently everybody else is taking a few breaths too.
Me too.
I'm at some point I want to remember to thank our planning team. A couple of them were here today. Monica Edgar from Concord Hospital and Corey Gately and Lindy. We also have Carol Furlong and Karen McAllister from the University of New England. And let's see, I think I'm going to leave somebody out. We got Corey, Carol, Monica. I think we got them all there. So any of you, how is this for all of you folks in the audience who are very, very good at this? How did this land? And do you have anything to add or to reflect about this?
Hello.
Hi, Susan.
Hi, that was excellent, by the way. And I think it's really wonderful to get the information reinforced over and over again, because it can be very difficult when you're getting tired and there's all kinds of other things. But what you said is exactly, I think, accurate. When I first got in the field, it was more about confrontation. And I can tell you, as I sat in groups, I closed my eyes and put my hands out. I just was so horrified. And I thought if I was one of the patients, I would be running away. And when they'd say, wow, they're really resistant, I was thinking I would be resistant too. So it's really wonderful to have seen the education and the changes in the field. And I just love the way you presented it. I don't know what the acronym, not the SBIRT, but the other one stands for. I might have missed it.
STIR.
Yes.
Yeah, it's screen, treatment, initiation, and referral.
Thank you.
Yep.
Appreciate it. All right. So thank you so much. And I don't know if if you're willing to share some of the screens. You know what I'm saying? I'm tired today. Sorry.
Sure.
Some of the education that we could share with some folks who are newer that would probably benefit hugely from it.
Sure. No, absolutely. It's all open source. This is, I might have put it together in a certain way, but it's not my original thinking, so absolutely. And I'm curious for folks who, I have a question, and I'm curious, like in your locations where you work, how have you deployed any of the screening process, the motivational interviewing, training of providers, any of this that we've talked about today? How has that gone deploying that in your locations, your organizations?
I'm really interested to hear about that too, Peter. And because Dan and I are sitting here in an empty office, and well, it's not really empty, but from out in the field, is motivational interviewing part of your training and what you do?
Sorry. Yeah.
Sure. Susan, go ahead.
Okay. I was going to say that we use it a lot in consults, and I find it really helpful. Just an example, yesterday went down to the ED, and someone who has relapsed once again on methamphetamine and clearly embarrassed and ashamed just said, nope, I don't need help, I'm good. And I said, okay, that's great, I'll just give you my business card, that's fine. And then he said, I've done this before, and it's all right. And I said, I can see that you look a little upset. And then all of a sudden, just the tears started coming, and he was very receptive to it. And so just bridging that gap. One of the things that you said that I thought was really interesting and true is that sometimes nursing, they do want us to make a recommendation for inpatient and call inpatient programs, but they don't understand that if the patient said, no, I have no interest, we're not going to spend hours calling so that the patient can then say, no, I'm not going. So that would be kind of nice to build a little bit more understanding for them, because sometimes I think they just think we're giving up, but we're not giving up. We're just kind of backing off for a short period of time, and hopefully be able to help out.
Yeah,
That's our
right.
experience.
It's that readiness component, right?
Correct. Yes.
Yeah. Yep.
Thank you.
Yeah. Stephanie.
Hi, Stephanie Heath. I do work at the Stu Convoy at Concord Hospital Substance Use Services. And a part of my role is I do a lot of education throughout the hospital with our staff on a lot of expert kind of motivational interviewing. And it's, I think the response has been hit or miss, depending on, I would even say like department wide, it's going to be hit or miss, and how it's received and how receptive people are to the information. I think when we worked in the emergency room, it's been harder to get some buy-in. They're seeing patients at their most vulnerable and defensive regarding their substance use, and so they're seeing some behaviors attached to that. So I think that that's been harder to get buy-in regarding utilizing some of this motivational interviewing and really having more empathy when working with people who are struggling with substance use versus some of the more inpatient units where patients are a little bit more stabilized. And so it's been an interesting experience providing some of this education and a lot of great extra information for me to kind of think about when working and continuing to offer the education and the training.
And you said, Stephanie, you said at Concord Hospital?
Yep.
Yeah. Yep. Do you know Bill Gunn when he used to be there many years ago?
No.
I know Bill Gunn.
I mean, it's sort of that, and that I'd be interested to know what departments are more or less entertained by this than not. I mean, we did Dan was mentioning earlier the sort of the project that we took on, and it was really what we call a substance use resource team training. And we had, 14 different trainings that people had to take, here and there. And the most positive feedback we received was on the live motivational interviewing and trauma-informed care, those two classes. We had other ones that people watched and, they got something out of it, and methamphetamine 101 and SUD 101 and how to do an alcohol withdrawal protocol. But they really enjoyed the live components of those two. That's the most positive feedback.
Yeah.
And I think that's hard to do hospital-wide, right?
Yeah.
To engage with people live, right, in a meaningful way, and so.
Yeah, we
Peter,
did a lot of them were done via we did a live Zoom meeting, and we did one recorded with some of the staff from one of our medical floors. But it was interesting, even though it was a recorded, a lot of the participants that were in the session as we were recording it got really into it, even wanted to do like a role play with some of the motivational interviewing. And so it was interesting to see how some people were really eager to just kind of get more experience and really kind of get the feel of utilizing that motivational interviewing.
Yeah. Thank you, Stephanie. Corey?
Yeah, I was just going to add that I have a couple of my staff here today, and I hope that they feel that the message they've gotten in regards to this is to always meet the client where they're at, right? And I think that message is, you did such a nice job saying that today, right? Like, not drawing someone down the road, right? But also, it's okay. I always give them analogies, right? And I say, we always want them to run the marathon, right? But some people are just getting started with walking to the mailbox. And so the whole idea of meeting them where they're at is, we need to applaud the walking to the mailbox and, and work with that. And what can we do with that? And so I guess I feel like I would echo some of what you guys just said. I think the ED is probably the hardest place for us. And I would emphasize that it's been years in the making for our ED, right? We've had coaches coming into our ED upwards of more than 5 years now, I believe. And we're just getting to the point now where I feel like our ED staff says, we need a coach for that. And I think they know that's because the coach is going to approach the whole situation differently than they will, and they're pulling coaches in I have one coach that has a dual role. He's an LNA in our ED and he's a coach, and he's like accidentally getting pulled into cases when he's there as an LNA. We tell him that he has to look down, and if he's wearing scrubs, he cannot do the other job. We really want him to, but like, it's just such a great example of the fact that they know that he knows how to ask those questions the way that he should, right? Because he's been coaching for a long time. So just, I loved your emphasis on some of that today. And the last thing I wanted to say was, I feel like sometimes we look at motivational interviewing or these concepts and think that they're like big and we need to study them and really, and I don't know, I just loved how simply you made it sound. We just need to ask the questions and not lead them.
Yep, totally.
stuff.
And that's where, you know, if anyone is and I know I use the word training wheels, but I really feel like it is that EPE model. You just give it to them and be like, just follow that. Just read that, put it, elicit, provide, elicit. Say that to yourself before you walk into the room with someone, right? And it just kind of creates this framework to have a conversation around. So I fully agree, you know, Corey, it doesn't have to be like this super sophisticated approach. You just ask them, you know, I don't know, I guess I'm overstating, you just be kind, but it's different than that. I mean, it's really intentional, but there's a you know, a humane element to it for sure. And there's, for those of you, I don't know if you've, oh gosh, I just spaced the name. The book is called oh, I just lost it. I'm sorry. I just got a flash up in my screen and it reminded me of something that I hadn't done yet and I lost. Oh, Dignity. There it is. The book is called Dignity. And the book is, it's all about sort of like why we preserve our dignity and the importance of, and how certain cultures, people die to preserve their dignity. And yet, you know, why wouldn't they lie? If they're willing to die to preserve their dignity, why wouldn't they lie? You know, and it's sort of just kind of for the individuals that sort of are still haven't kind of got out of the, hey, they lied to me, they should be honest to me kind of mindset. This is just another sort of way of massaging that sort of, they're just protecting their own sort of, they're saving face, essentially, you know, in our colloquial English.
So Peter, I just wanted to say that you did a great job and you covered your 500-page book in a relatively short period of time. And yet it still looks like a whole lot of work. And like, this is something that you do if you have an hour with somebody. So I just wanted to highlight in your very last example, as you were talking there, how you said, but, oh, our 15 minutes is up. That, you know, all this stuff you're talking about, while it seems so complex and like it would take a long time, can really be done in a very short period of time. And you said that at the very beginning, that it's much better to have those. It is just like with teenagers, you want to have a whole bunch of short conversations rather than one long one, because they stop listening after the short time. So, so I just wanted to have, for the people here that are not mental health or substance use clinicians, but are more direct medical providers like nurses and whatnot, that it is not something that you have to do all the steps in one fell swoop. But that elicit, provide, elicit is a way of kind of saying, you can do this, some of this, you can start this in 3 minutes.
Oh, absolutely. And a lot of times, you know, therapeutically, they call it joining. Sometimes joining can happen in seconds. Right? I mean, a nurse coming up and touching a patient's arm and being like, are you okay? Boom, done. Done. I joined. There it is. Or you look really frustrated right now. Yeah, you know, I am, because blah, blah, blah. So a lot of this can happen, you know, in a very, very short period of time. Sometimes you got to, you know, you've got to massage that for a really long time and you know, kind of get it working. But sometimes it happens really quick. And you're right, you know, Lindy, it doesn't all have to happen in one fell swoop. Yep. Episodes, chapters, episodes, segments, you know, little bits.
Sentences sometimes.
Yeah, totally. No, absolutely.
That question, that statement, that affirmation, you can see somebody turn and you can experiencing them, and when they know you care.
Yeah.
Okay, any other comments? If not, and please jump in if there are, it is time for us to move to the closing out this presentation, this excellent presentation. Peter, thank you so much. You have not only shared the spirit, but you have energized us with the spirit of MI and the desire to be better. And it was everything that I thought would happen and even more.
Excellent. My
And
pleasure.
we're going to talk briefly about the resources that are available through Growth Partners and through their website, nhtac.org. That is a terrific site. Let me give a personal testimonial. I'm there often every week, at least twice a month, and whether I'm going in to find a presentation or to get a link for somebody else, but I'm rather constantly on that website. There's a good deal to be gained from spending time on that website, and I encourage you to do so. These are our partners. The resources are free, and there is so very much there that I think will be of help to you in your practice, no matter what area you find yourself in. This is a place for answers and resources. Let me also say that we do have another community practice coming up this year. That will be on December 15th. We have already recruited a speaker. Thank you, Monica Edgar from our planning team. Tara Davis Thompson will be joining us, and we'll be talking about working with patients who are Black, Indigenous, and people of color, and particularly people who have had the experience of being refugees or immigrants and becoming new Americans, and some of the nuances and getting to better know certain populations. Along with that, very recently, Dr. Bobby Kelly from Exeter, one of our close friends and one of the co-project directors for his hospital, has completed a really fabulous 45-minute presentation on the treatment of substance use disorder in people who are LGBTQ+. That particular presentation resides on the Southern New Hampshire Area Health Education Center site, and it's also accredited for a 3/4 hour of CEU credit. Now we come to the point where we ask something of you. Would you please, the evaluation link is in the chat. If you can click on that and complete it sometime soon, we'll be very, very grateful. We do use this information. Our planning team receives this. We use it to plan forward. And the feedback that we have had about providing practical skills, I think, has served us extremely well. And hopefully that you have found the content of these presentations to be to your liking and valuable for you. Let us know, please reach out to us. I'm going to turn to Mana and Stephen, my handlers, and say, have I missed anything?
I think you've done a great job. Yeah, thank you, Dan. I think that's everything.
We made it through the slides. We were going, wow, that's a lot of information to cover in that. But very much thanks to Mana and to Stephen. And we are finishing a few minutes early, but we'll use that overused phrase, give you back a few moments in your day. Anything before we depart? And if not, we will see you back here on December 15th, and that information should be coming to your email inboxes soon. Thank you so very, very much.
Thank you all. Have a great day.
Thank you, Peter.
You're welcome.